Okay, it's 1 minute past 3 here in the UK. Welcome everyone to our fourth IFMRS Roundtable. I'm Gudrun Stembeck and I'm co-chairing the Roundtable together with Patricia Guras Camacho. And this is the two of us that you see on the screen, and obviously Federico here. And unfortunately, we can't see you, but that's fine. Keep your microphones muted, and like later on in the breakout rooms, obviously, it would be nice if you could turn on your cameras. So thank you very much for making the time today to attend, because obviously we are covering a lot of time zones, and obviously, for some of the time zones that is a particular challenge because it might be very early in the morning or really in the evening. So we have about participants from 30 countries registered and covering basic science, orthopedics, rheumatology, and more. So then just before we really get started, I would like to have a few housekeeping announcements. So first of all, this meeting is recorded, but we do not record the breakout session. So if there's anything interesting, please take notes. But the rest of the meeting is recorded, so you can actually listen to it at a later time. So please ensure that you remain on silent when you're not speaking to avoid the background noise. And when you want to say something or have a question, then please raise the hand button that you can find on the lower screen. And then I will call you. And then also don't forget to actually lower the hand afterwards. So also please do use the chat function if you need. And if you have any technical problems and the chat maybe is not available, then just email Chris or Federico and they will, help you. So the meeting is, as I said, recorded, and it will only share it with IFMRS members who could not be here today. So I have a couple of slides here that I would like to share with you, and I need to see that this is actually working. Okay, just one sec. So Federico, can you tell me that you can see my slides?
Yeah.
Yeah, you can?
Yeah.
Okay, perfect. So so just like a brief overview of IFMRS, you have here all the member societies. So we are growing, and it is really great to see this growth over the last couple of years. And we also have affiliated members. So I think it is a growing community, and this is what we like to continue doing, and also involving, like other specialities that are linked to musculoskeletal health. So in general, the challenge, and you probably all are aware of that for musculoskeletal research or the musculoskeletal community, is that despite the huge and well-documented impact on population health and global economics, the conditions themselves, they are under-recognized and under-prioritized. And that means that we have less treatments. So what we want to do is obviously change that. So we think that there is insufficient interdisciplinary collaborations within the field of MSK practice and research. And we can only change that if we are working together. So we actually have, or the IFMS has several aims and focus areas for the next couple of years. And the first one is really influence. And that means that we make MSK an international priority by increasing profile, and also work on the priority and MSK research and global health policy. Then really important, this is why we're all here, is actually network. So improve collaboration, broaden our community, and provide added value to member organizations of the IFMRS. And we also want to obviously deepen and disseminate knowledge in MSK research. And with that, excuse me, we hope that we can build and provide a home for generally global diverse movement. So it's really about growing the influence, giving a voice to this under-recognized or underfunded condition, and work together. And so the next slide shows a little bit how the IFMRS leadership envisaged this, and thank you for Federico for preparing this really nice overview. So what we would like to have is really, we have our member organizations with a purpose and value that is here, the root of everything. And then the tree really grows up into different branches. So we have the knowledge branch, and then the really large part is our network branch. So we have to outreach, engage, and that is really where these where we have MSK professionals from different areas coming together, working together. And then ideally, we translate research that is undertaken into a wider health agenda. And what we want to do then here on the left-hand side is obviously influence governments and the WHO to actually change what is happening at the moment. And clearly, the dissemination of knowledge. Sorry, they're just having the thunderstorm, so I hope you can't hear that. So the dissemination knowledge and the pooling of knowledge data is essential. So this is really what IFMRS is trying to achieve. And we have developed a couple of resources which you can actually access via the IFMRS website. We have the Hubble as an online learning platform. We have the knowledge portal where we have large amounts of data deposited, which can be used for data mining for research. And then we also have the virtual library for key resources from across our community. Okay, so this is me just with the introduction, and I hand over now to Federico to talk a little bit about our Global Action Plan.
Thank you, Gudrun. So I'm just going to say a few words about the Global Action Plan, which you've all seen and hopefully had a chance to read. It's on our website. Some of you have been involved in producing it, so thank you for all your input so far. The Global Action Plan is a framework for tackling some of the biggest challenges facing our community as regards education, knowledge sharing, collaborative working, and captures key recommendations from all parts of our community and for all parts of our global community, from national research societies to individual research professionals, governments, and international organizations. So there's something in there for everyone. It's designed to be a blueprint for action, which means it doesn't tell us what the answers are for every part of our community or every part of the world, but it gives us something to work from and to refer to when we're taking forward its recommendations at the national, regional, or international level. It's also designed to be a living document, which means it will be regularly reviewed and updated, and that's what we're doing today. Finally, it contains a list of useful resources in the last section, including all the various ones that we as a federation have developed with our members and our stakeholders over the years, and which we continue to develop, all of which are freely available on our website. And no doubt there are many more out there that we could include, and we'd love to have your thoughts and suggestions in this respect. So the Global Action Plan forms the backdrop to much of today's discussions. We launched it last year as a result of all the previous discussions we've had over the past 3-4 years. But before we do that, we're going to have some presentations from some people from different parts of the world, sharing some of the things that they've been doing in their countries, which speak to one or more of the recommendations in the Global Action Plan, and which hopefully can give us some food for thought when it comes to taking part in the discussions afterwards. So I think we can start with the presentations, Gudrun.
Yes, absolutely. I was wondering if you just introduce the first speaker or give the microphone to the first speaker. That would be fantastic. Thank you, Federico.
So Our first speaker is Dr. Albert Macha, who I believe has joined. So Albert, would you like to share your screen and start your presentation? I'm sure I saw Albert joining. Albert, are you here?
If not, maybe then we just go to the second speaker. I think it's hopefully okay.
Yes. Unfortunately, we do have to stick to quite a tight timetable. Okay, well, the second speaker is Dr. Paula Arnias, I believe, from Peru.
Hi, everyone.
There you go. Hello.
Hello.
Should I share?
Yes.
Okay, let me see. Is it sharing? Can you see my?
Not quite, but it's getting there. Yeah.
So you can see it now?
Yes, thank you.
Okay. Hi, well, good morning. Well, in Peru, it's morning, everyone. I'm Paula Arnias. I'm a physician specializing in physical medicine and rehab at National Hospital Edgardo Revalletti Martins in Lima, Peru. I'm here on behalf of Dr. Rogers, so thank you for having me. Well, Revalletti Hospital is located in Lima, Peru, and was founded in 1958. It's one of the largest public hospitals in Latin America. Our hospital serves as a national referral center for complex cases from all over Peru. So we have a physical medicine and rehab department, which in 2021 underwent significant changes and upgrades aimed at improving patient care. We introduced new treatments such as prolo, ozone, platelet-rich plasma, and extracorporeal shockwave therapy. So our department offers specialized programs such as musculoskeletal rehab, neurological rehab, spinal cord injuries, pain management, pediatric rehab, and cardiac rehab. We work with a multidisciplinary team that includes physiatrists, physical therapists, occupational therapists, speech language therapists, among others. So as we look towards Rehab 2030 goals, our efforts have centered around three key goals, which I've mentioned here, being leadership, research capacity, and networks and partnerships. So, as previously said, we aim to create strong leadership in rehab care. That's why we're systematically assessing the rehab situation at the national level across Peru using the STARS framework. And this will help us identify key areas of improvement in rehab in Peru. No? And our physical medicine and rehab department is proud to be the first public hospital department in Peru that is initiating the CARF accreditation process, which will solidify our position as a leader in rehab care and research in Peru. So, regarding research capacity, currently there is a limited research in the field of physical medicine in Peru. And our primary challenges include lack of funding, resources, and we have a weak research culture. However, we have seen this as an opportunity to grow. And the first step we have made is we've made an external call, and we're encouraging research collaboration among various groups, that being undergraduate students, general practitioners that like PM&R residents, physiatrists, and epidemiologists. Lastly, taking into account the networks and partnerships, our hospital is part of the World Rehab Alliance. That the mission is to support the implementation of the Rehab 2030, and we're focusing on the work streams of emergencies, primary care, research, and workforce. we are also working in establishing a partnership that Revalidati establishes a partnership with CANOSC, which is an organization dedicated to treating spasticity in a multidisciplinary setting. CANOSC leads an effort in high-yield educational exchanges, which that's our aim, and so that our professionals can continue developing and improving in patient care. So we hope that in partnering with them, Revalidati can further enrich its services, particularly in the area of spasticity. So thank you very much. We're actively working towards the goals of Rehab 2030 by improving patient care, expanding research, and forming global purpose. Thank you.
Sorry, I'm just pressing too many buttons here. Thank you so much. We will have questions at the end. So if you have any questions for Paula, please note them, and then we will be asking. We have a small plenary, like a question and answer session. So thank you for now, Paula. And I give the screen and the microphone to Albert.
Hello, everyone.
Hello.
Good morning, good evening, good afternoon. I'm Albert, and I'm from East Africa.
Albert, do you want to share your screen and start your presentation? Albert, are you still, can you still hear us?
Might be a funny internet connection now.
Wow.
He's currently mute. I think he needs to be unmute.
Albert, if you can hear us, can you please unmute and let us know? There. Would you like to start your presentation, Albert?
Hello?
Yes.
Yeah, now we can hear you. Sorry, we lost you.
No, I've shared the screen. Can you all see the screen?
No, I think I don't know if this is the start of your slides. Because we can just see, like a picture.
No, I
Elephant and the lion.
do have the slides if you'd rather I use them.
Maybe it would be easier, Federico.
Yeah.
Albert, shall I share my screen and you can?
Yes, please. That would be best,
Yes.
because we
All
represented,
let's
because
do that.
Maybe
it's rejected to
you could
share.
stop share.
Okay, can you see my screen now?
Yes, thank you. We can see that.
Okay, hold on. We'll just start the slideshow. Okay, Albert.
Yes, please. Thank you very much, Federico. And once again, sorry for the technical glitch. So as introducing myself earlier, I'm Albert Macha, and I'm a practicing orthopedic surgeon in East Africa. I'm based in Dar es Salaam, Tanzania. And I'm just going to share an overview of what so far is going on as far as orthopedic training is in Africa, because this partly addresses most of the MSK condition in the region. Next slide, please. So this is an overview of what has been happening for the past 5-6 decades. So currently we have on average about 200 universities in the region, and this is in sub-Saharan Africa. And less than
Hey, Mama, sorry that I was on a meeting yesterday. Thanks for bringing FCAT to us.
Hello.
Federico, I think
Hello.
did they
Yes.
Am I back online?
Yeah, now
Right.
you're back online. Yeah, because you were quiet for about 2
Due
minutes.
to
Hopefully
the
it's more
limited number
stable now.
thank you. Sorry. Due to the limited number of trained specialists in orthopedic and trauma in the region, some countries have gone to the extent of enrolling non-medical personnel, what they call orthopedic clinical officers. And this has been done as a pilot in Ethiopia and Malawi for the past a decade and a half. And these people are given a diploma, a 2 to 3 year diploma in emergent and urgent need MSK condition, basically trauma and infectious condition of joints and bone. And these are the people who are taking care of the patient in the region. And this is quite challenging because majority of the MSK conditions require an ample knowledge in anatomy, physiology, and other fields of medicine. Next slide, please. So currently, with a case example of East African
No, we lost him again. So maybe he tore off his camera. It can help us a little bit.
Right. Can you hear me?
Yes.
Okay. So we've lost Albert.
Yeah. If you have his presentation, maybe you can go through.
I could, but I'd much rather he did it. Well, we are okay for time at the moment. I'm just wondering whether we should come back to this. Gudrun? Shall we do the next presentation if Albert is struggling with his connection? Gudrun?
I'm good to go. Would you like me to?
I think that makes sense, Deborah. Please, that's all right.
Okay, I'm just going to share my screen then. Just let me know you've received it. You can see my screen.
Yeah.
Thank you very much, everybody. And good morning from Canada. Good afternoon, good evening from elsewhere. I'm Deborah Kopansky-Giles. I'm a professor at the Canadian Memorial Chiropractic College and in the Faculty of Medicine, Department of Family and Community Medicine at the University of Toronto. And it's a pleasure for me just to give you a very, very brief summary of a really interesting project that we've been undertaking in Canada. You can see the project team. This is an international group of individuals that are really interested specifically within musculoskeletal health in spine care, particularly in light of the enormous burden of spine conditions. So I'm going to briefly talk about this specific research project, which is one of many that we are involved in. Of course, I need to declare as a member of an academic institution that we have no conflicts of interest. I did want to acknowledge the funding agencies, both international, national, and federal government funding for this work, and the multiple universities that are participating with co-investigators on this team. In Canada, we do a land acknowledgement, and especially important when we're working with Indigenous communities. And the land acknowledgement is to recognize that the work that we're doing and where we are in this work is home to Indigenous people from all over the world. And we recognize the importance of that, and that we're reforming our relationships with one another, moving forward in partnership with Indigenous nations in Canada and around the world towards reconciliation and collaboration. And we've had an amazing collaboration with the Cross Lake community in Northern Manitoba, where this work is being conducted. So why, I guess the question is, why World Spine Care and the Global Spine Care Initiative? I'm just going to very briefly describe that World Spine Care is a charitable organization that was created by, founded by Scott Haldeman in 2009. Scott Haldeman is a chiropractor by training, as well as a physician and a neurologist, and led the neck pain task force for the bone and joint decade years ago, and really saw the urgency for delivery and availability of spine care in underserved regions. So the organization has been around since then. We provide spine care in underserved communities through collaboration with local governments, academic training programs, health professionals, and volunteers, health professional organizations as well. So it's a really nice collaborative effort. And we currently have programs running. The longest running program was started in Botswana, and we currently have programs as well in Ghana, Dominican Republic, India, and Canada. Now, the Global Spine Care Initiative grew out of World Spine Care, and it is kind of a research arm for World Spine Care. Which now the research is really overseen by an international World Spine Care research committee. But the GSCI was composed of a scientific secretariat of 63 individuals from around the world, from all different fields, different economies, different countries, different backgrounds, including people with lived experience. And it was really to look at proposing new model of spine care. So this work was completed in 2018 after 4 years, and it was published in the European Spine Journal as a special supplemental issue. So at the very end of my slides, I have acknowledgement and references for that people can take a snap up if they'd like to. But why spine care? Well, we know that low back pain is the #1 cause of disability globally, and neck pain is number 4. So we also know that disability is for spine pain is disproportionately related to how it impacts people. It impacts the women, elderly, rural, remote, and Indigenous communities, the lowest income quintile folks, and lower income countries disproportionately compared to other individuals. We know that specifically for this project that I'm going to talk about that we conducted in Northern Canada with a Cross Lake Indigenous community, we know that low back pain was important to understand the impact of opioid use. And in the Western world, for sure, opioid crisis exists, where there's been enormous impact of opioids on the health of individuals and the overprescription of opioids for chronic pain, in particular non-cancer pain. So low back pain is the #1 indication for prescribing opioids. Over 50% of users of opioids are receiving for back pain, and neck pain is #4, exactly matching the disability burden. Opioids are also overrepresented and overprescribed in remote Indigenous communities in Canada, 5.6 times higher than they're prescribed among other communities. And there's multiple reasons for that, a lot related to lack of availability of non-pharmacological approaches to managing chronic musculoskeletal and spine pain. So this is why we really wanted to undertake this project. I just wanted to give you just a really quick look at the Global Spine Care model of care, which really walks through different classes of spine conditions or spine pain. And through this extensive period of work funded by the School Foundation over a period of 4 years, was looking at all the level of evidence for each of these types of interventions that are provided for spine pain, and also the presentations that people might present with. So you can access all of this information by going to the GSCI website, gsci.org, essentially. The study objectives were really to assess the fit and readiness to implement the GSCI model of care. So while we had this great model of care, we hadn't actually tested it in the real world environment. So we have this funding to test it in Northern Canada in an Indigenous community where we know it's incredibly underserved, where there's a lack of MSK care provided there, and to look at how we study that, and to assess the feasibility of the model implementation from the perspectives of leaders, clinicians, patients, and community residents. So we looked at a mixed methods approach to doing our work, and these are the three areas that we conducted our work. And I'll just really briefly share you the results from that. So we did a chart review looking at the types of problems, MSK problems people were presenting with. It was a one-year respective, and we looked at 41 charts. And this is what we found. 63% of people presented with low back pain, 10% thoracic spine, 7% neck pain, 19% extremity pain. And 22% of those individuals prescribed opioids. We also did a community health survey to look at the burden of spine pain in the community, and we actually had 135 households that participated in that survey. And we see here that this is a similar report to what they were presenting to in the nursing station where the services are delivered in Cross Lake. Then we did qualitative interviews with leaders and clinicians to get a deeper understanding of their perspectives and how do we facilitate the integration of musculoskeletal care through the GSCI model in the community. And so we had 19 individuals participate in the focus group, and they really brought to us expanding knowledge about their culture, environment, the importance of the culture, the importance of their environment, the context in which they were living, where accessibility to healthcare is very, very limited, as well as many other environmental factors like a forest fire, which cut them off for months from receiving any care, for example. And then how it's important to set expectations in assisted community with their belief systems with respect to delivery of spine care. We also created a community movement program to start getting them exercising, and also to think about how that should be designed and what would be meaningful for them. So integrating Indigenous dance and ways of moving and their knowledge around movement and how it integrates with their health was really important elements. We also studied this component, which was also quite successful. So in the really brief 7 minutes, or maybe 8, the takeaway messages from this work was the access to high-value spine care is severely limited, and leaders and clinicians have worked with us to co-design a culturally adapted implementable model of GSCI in the community that we see an early indication of reduction in use of imaging and opioids, and that chiropractic, acupuncture, manual therapy like physiotherapy and massage therapy align well with the Indigenous ways of healing, and that when we remove economic barriers and make access available readily, it's readily used, highly utilized and valued, and that a co-design movement program is feasible and has the potential to prevent for preventative community health. So this is the work that we're doing. We've published several papers. I want to acknowledge World Spine Care and GSCI and all these individuals that participated and funded our project. And there's been several papers published regarding this work so far and are in submission. And this is the European Spine Journal special supplemental issue where the GSCI model of care is published. And happy to share more information during the Q&A. Thank you so much.
Thank you, Deborah. That was excellent. We went through all of our talks now. So Patricia, if you can join me, we can now take some questions. So please.
We do have a couple more.
Oh my God, I forgot, because we have a pre-recorded session. I'm so sorry about that.
And,
yeah, so Federico, if you can,
So Albert's back, so I might try again picking up where
okay.
I'll share my screen. Albert, are you ready to go?
Yes, please. Yes, please. And sorry for the inconvenience.
No worries.
I'm up country and the network is a little bit stubborn here.
Completely understood. Sorry about that.
As I was saying, for the first few slides, I was just trying to shed a light on what's the challenges to address musculoskeletal condition in the region, as far as there's less personnel who can pick, detect, and manage these patients. Next slide, please. So currently, I was saying that for the past 4 decades, the focus on African health systems was more on infectious prevention, the tuberculosis, HIV, and malaria. And then since now that has been a little bit controlled in the past decade, now the trend has been changing, moving forward to the new pandemic in the region, the road traffic accident and trauma. And now this is the new thing, which is bringing more volume of patients to our facilities. And despite all that, our government have been notoriously not providing enough allocations as far as NCDs are concerned, and which includes most of the MSK condition and NCDs, non-communicable diseases, and trauma now, even though it's one of the leading cause of death in sub-Saharan Africa, compared to the total number of deaths per annum of malaria, HIV, and TB, still trauma is unrecognized in most of the health annual budget in the sub-Saharan region. Next slide, please. So why this presentation? The International Federation of Musculoskeletal Research Society has been bringing up the idea of collaboration between different partners, both internationally and locally, to bring about research. And research in this sub-Saharan African region will address the gap on the existing burdening musculoskeletal condition. Like from the former presenter, pain has been one of the most neglected things in the sub-Saharan Africa region. People are more focused on anger, trauma, and other infectious conditions, but MSK, other musculoskeletal conditions like pain are not even recognized at all as a thing which will cause disability and morbidity to most of the people in the region. So this research, if we're able to collaborate, will bring about evidence-based medicine to address things which are really affecting people's daily living, and not just theoretical from what maybe other region of the world have published. The sub-Saharan Africa is a different kind of population, and I think if we can conduct adequate research in the region, we can pick up different musculoskeletal conditions which are burdening people here, and we can address this at international and local level. And the International Federation of Musculoskeletal Research comes in at the right tool to collaborate both with professional, like the medical personnel, and non-professional, the community leaders, and other people who are engaging to see these people at first level in these facilities or in the community, to address different conditions like congenital deformities, rheumatological condition, and other MSK conditions which are not even in the national guidelines of disease management. Next slide, please. So how do we move forward from here? So as the action plan has been brought up last year from the Global Action Plan Initiative by IFMRS, collaboration is the key component. And the reason for this presentation is to seek out different partners who are ready to collaborate with people who are practicing in the region or even outside the region, who have interest to address any type of musculoskeletal condition. Right now, trauma is one of the leading musculoskeletal conditions in the region, but we have so many other conditions: congenital anomaly, club feet, pain. We see a lot of spine condition, degenerative condition, joint condition, rheumatological condition, which even sometimes in most countries, they don't even have the right diagnostic tools to address. So this collaboration will bring about the gap which is there by even doing baseline research to pick up which condition are readily available, but still very minimally looked by the national and regional health systems. So by doing so and offering mentorship skills through people who have done different research in various fields in MSK, we can develop a simple consortium where we can design simple study methodology which will not require much funding, but which will impact the communities and people within the region. And this is where partly we can start by education, where on the next slide, you will see that, please, next slide, please. Currently, with partnership from the Orthopedic Research Society and International Federation of Musculoskeletal Research Society and our institution here in Dar es Salaam, we are trying to organize a series of webinars where we're going to share with practicing clinicians in the region. We are hoping to reach about 250 practicing orthopedic surgeons in the region to start raising awareness on the importance of research in MSK conditions. So I hope where we can bring about this presentation in the next month or two, we're going to raise awareness and how people can balance their clinical practice, even though it's overwhelming. Still, they should balance some time to engage in research also, because the research is what will give you feedback of if what you're doing is relevant to your people, or you are going, or you're not reaching the needs of the community at large. And then there are different programs like the HBNU, the Harvard, Boston, Northwestern, and University of New Mexico, mentorship and fellowship programs where they have the Fulgate Global Health Training, where they offer research assistance for new researchers in the low and middle income countries. And this is where most of the sub-Saharan countries fall in. So if we can have people in the community and even in the International Federation of Musculoskeletal Society who are interested to do research in sub-Saharan Africa, this could offer it as a mentorship and fellowship program through this program. And then we can develop further to assist the underlooked musculoskeletal condition in our region. And also, to help even start registries, because most of the people who are attending most facilities in the region, they're not registered. So in the end, when you're doing an annual audit of which condition maybe as far as musculoskeletal condition are concerned, so that you can address them maybe in the future as far as budgeting and planning is concerned, we don't have registers for most of the musculoskeletal condition in the region. Like for rheumatological condition in my country, awareness for rheumatological condition is rising up, but if you go to regional level and district level, apart from the national level, people are not even aware of the impact of rheumatological condition as far as people's health and well-being is concerned. So even having a registry will help us, and in the end, to even incorporate these things in the curriculum, so that people, even when these medical students and residents are trained as far as orthopedic is concerned, they can come about with ways to tackle these challenges which are overwhelming us in the region. Next slide, please. So to date, we have collaboration from different societies, where some have been in the form of education, some have been in the form of seminars, some have been in the form of exchange programs, where people from the developed world have been coming to Sub-Saharan Africa, specifically in Eastern Africa region, through this different organization which I'm sharing on the screen. And they've been able to somehow uplift the level of care and the awareness in the region, but still we are lagging far much behind. And I think through further collaboration and exchange of ideas and visions, we can improve the management and approach of musculoskeletal condition in the region. And I think that's the end of my presentation, and sorry for the inconvenience. Thank you very much.
Thank you so much, Albert. This is brilliant. So I think we should move on, right, Federico?
Yes.
To the next presentation, so that we
So
still have...
what I was going to suggest, Gudrun, given that the next speaker has recorded their presentation because they can't be here today, maybe we can take some questions now for the current presenters, and then if we have time, we can play the recording.
Yeah, I think that that is a very good idea, because we are running slightly behind schedule.
We're okay at the moment, but if we play the recording, then yes.
Yes, okay, excellent. So yes, as I already mentioned earlier, if you have any questions, please raise your hand, introduce yourself, and you know, have the question ready for, or say who the question is for. You can also pop it obviously in the chat, and I'm happy to read them out.
If it's okay, Gudrun, I just wanted to sort of kick off a bit of the conversation while we wait for questions. And I just wanted to sort of also support what Albert was saying with respect to the unavailability of services, the significant underserving of MSK clinicians. And it's shocking in Africa, and we hear also from Albert, but it's actually happening everywhere. I'm in Canada, which we consider a very wealthy nation, and excellent health services. But here, even musculoskeletal healthcare is underprovided significantly, even though it has a massive burden and a huge economic cost. It's very underprovided. People can't access it because of cost. It's not funded generally within healthcare, especially conservative musculoskeletal care. So I would say like the problems are very symptomatic also in other parts of the world. And you know, World Spine Care is trying to fill some of those gaps, but we see the same issues here. So I think we have a common cause to collaborate globally. And I really appreciate IFMRS working with us on that.
Yeah, I think I completely agree with you. I think it almost feels that it's still like, oh, you have back pain. Oh, well, whatever. You know, it's a bit of, well, what do you mean? You know, like, it's not really relevant, even though it's so deliberating for the, that was the wrong word, but you know what I mean.
Debilitating.
Debilitating. That was the word I was looking for the person who's suffering from it. And if you look at also in the UK, it's the same. You know, like if you look at the number of work lost because of that, it's huge. So it is not really clear why there is no, I don't know, not a real big drive to actually do something about it, besides actually giving people really strong painkillers and you know, making them dependent on the painkillers. So yeah, I don't know. I mean, do you have any direct questions, for example, for Deborah, Albert, Paula? bit quiet here. So then I have a question for you, Deborah, because you can see you right here. So you know, obviously you were asking all your participants, you know, like how we could actually improve. How can we make it better? So do you think that you will find a way forward? Because obviously, you know, it's more about, you know, physiotherapy, you know, maybe helping people, because often it's also the way they work, maybe. Do you think that there is an agenda that you could push at the government level?
I'll actually tell you and just try to be brief. So I'm involved in this a couple of projects. The second project that I'm involved in is also funded by our federal government, an interesting employment and social development branch. And they funded me to lead a project across Canada where we integrated musculoskeletal care into funded primary care settings. And so that is also really interested, because a lot of the conservative care, like if you're looking at massage therapy, physiotherapy, chiropractic, osteopathic care, that's not funded generally within our health system. So we're actually advocating to say that we know in North America that 40% of every family physician's day is MSK. They actually don't want to deal with it. They also aren't experts in that area. So we proposed this study, which they funded now. So the nice thing is that in the areas that we did the integration of this care, the provinces are now looking at maintaining it. But I've also now been connected to our federal government and have had now my first meeting and another one second coming up in Canada about with a woman who's overseeing workforce strategy development. And they hadn't thought about MSK workforce as a workforce. They're just thinking about profession specific. So now we've opened this sort of idea about thinking about a workforce to deal with specific issues. I will say, and Federico will know that with my Global Alliance for Musculoskeletal hat on, we've been working really closely with the WHO to advance this at global levels. So we know that the WHO is finally being vocal about musculoskeletal health. They've had 2 webinars already this year. They have an information sheet now on it, and they're going to host a high-level meeting on musculoskeletal health in the new year that we're actively working with them on. And that's really to raise priority among member states. So we're hoping it's going to be contagious, catching on, and seeing that at also international and local levels. There's a commitment now, because we also know that the highest economic burden to health systems almost everywhere is musculoskeletal conditions. So I don't know how they can not pay attention when it's costing them so much money too.
No, because, you know, you can always give somebody a cheap painkiller. Anyway, hopefully, you know, like all the good work is you know, leading to, you know, like developments that are actually really helping the sufferers. Lucy, yes, you have your hand up.
Sorry, I was trying to unmute there. Thank you very much. Great presentations, everybody. Albert, I had a sort of question, observation for you, really. We're doing some work across sub-Saharan Africa, in Gambia, South Africa, and Zimbabwe in fragility fractures. And a lot of what you said hit home for some of the work we're doing. And I just wondered if you are doing any work with traditional healers, because we're finding that we have traditional bone setters in the Gambia, which I think you also have in Tanzania, which are sort of a bit of a stopping gap for musculoskeletal care, because sometimes it's causing a bit of a delayed presentation to medical facilities, as well as it's sometimes difficult to actually engage them in the research process. I just wonder if you have experience in that as well, Albert, and perhaps if so, we could think about joining up and having a conversation away from this as well. I hope that's appropriate. And it's not really a question as such, but I hope that's okay.
Absolutely, yes. Albert, it's difficult to hear you yet, just.
So can I proceed to answer the question?
Yes.
Okay, so yes, this is the challenges we are facing here in Tanzania and in around the region. So fortunately, I've been working with AO Alliance for the past 3 years, and we've been engaging with faculty members from this about 10, 11 countries in the sub-Saharan Africa. And when we sit around and to address the burdens, one of the burdens is still the traditional beyond setters. And here, even in the capital city where I live and practice medicine, they have raised up in the past 2-3 years quite a number of traditional bone setters. So even in fresh acute road traffic injuries in urban setup, the first thought primary care, people are running to these traditional bone setters, and then some of them will end up converting their injuries from closed injuries to open injuries, and then they'll come with complications, infection, and their treatment going forward becomes very challenging. So yes, it is true we are facing quite a number of traditional bone setters, both in the capital cities and in the rural. And in the rural, it's a different case because sometimes the hospitals are about 300, 400 kilometers from where the primary trauma occurs, where they can get orthopedic care for the trauma. But here in the capital city, where some hospitals are within a kilometer or two, still people, their mentalities is to seek first the traditional bone setters. So I think I'm open to discuss this further outside the conversation. Thank you very much.
Thank you so much, Albert. I'll get in touch with you if that's okay.
Brilliant. Thank you so much.
Thank you.
That's already, this is what we would like to facilitate. Federico, which is wondering, do we have time? Because I don't see any more hands up for the last presentation before we go into our breakout rooms.
No, I would suggest going into the breakout rooms. We can share the presentation afterwards. I'm sure.
Absolutely. Yeah, because obviously it is a recorded presentation, so we can do that then.
Yeah. Question
Oh,
from
no.
Nancy.
Yeah, there is a question by Nancy. Yes, go.
Hi, good evening. It's not a question. My
Hello.
name is Nancy.
Hello, Nancy.
From Kenya. Yeah, I'm a physiotherapist. I'm happy to finally be able to attend this session. Unfortunately, I've been seeing them and I've been having conflicting activities like right now. I want to say that this is a very good initiative to be able to enhance multidisciplinary care in musculoskeletal issues, because especially in sub-Saharan Africa, this is quite a big issue. And I'd say because of limited resources, we find that you're not really able to make the capacity the way it's supposed to be. So this is a very much welcome initiative. I'll be following up to see how much you can be able to collaborate together. I'll not be able to join in the breakout session, but I'm happy to be continuing joining this group to be able to add more to this. I work at the university as a lecturer, so definitely this is a welcome way to go. Yeah, thank you.
Perfect. Thank you so much. And hopefully, like maybe with Lucy and Albert, you can join and, develop new ways how we can actually raise awareness, but also find, solutions to the pressing problems.
Yes,
Okay.
definitely.
Thank you so much,
Thank you.
Nancy.
Thank you. Yeah.
Okay, so obviously, just like a brief summary. So we had our presentations. I thought they were all really super interesting, and obviously showing different challenges and solutions to problems. And I think it just brings us back to where we actually developed our global action plan. And Federico, do you have a link that we can maybe put into the chat for if somebody wanted to just have a brief look again before we do all the questions in the breakout rooms? That would be fantastic.
Yes, it is available on our homepage. That's the easiest.
But I was just thinking so that people don't need to go, because I'm just like a bit concerned, like if you then have to look, then maybe you lose the link.
Yeah, if I just put our homepage in, it's right on there. So all you have to do is scroll down.
Perfect. Yeah. Okay. Super. Thank you. Okay. So then, are we ready with the breakout rooms, Chris?
Great.
Okay.
So Chris has put in the chat the list of attendees, at least the ones that we know registered, with a number next to each. That tells you which room you're going to be in. So now we're going to open up the breakout rooms. There's going to be a facilitator in each of the rooms. If you look in the chat and find your name, it's by alphabetical order, first name. Look at the number next to it and then join that room. Okay. So you should have a screen in front of you. You should have all have the option now of joining the room. Chris is going to make sure that anyone who's not sure knows where to go. And if your name is not on there, then you can choose whichever room you prefer. Okay?
Frederico, Ade here. So I know I'm in room 4. So what do I do to get to room 4? Chris?
I'll be helping allocating some of the people if you can't join the room in just a moment. So
Okay,
just
thanks,
give me
Chris.
1 minute if you don't mind.
No problem.
You can't see, can you see the rooms at all?
No.
It should be on the top of the software. Okay.
I can't see anything.
Okay, let me just do it in a second. I'll do it.
Thank you, Chris.
Sorry. There is a button at the bottom right-hand corner with breakout rooms. If you can't see it, you should click on there and you will see the list of rooms.
I still can't see it, but Chris has kindly said he would help me.
What I see is bottom right is 3 dots. You click on
Yes.
that breakout room.
Hi.
Then you get a pop-up.
But it's not showing up in mine, so
No, it's not in mine too.
No,
Yeah, me neither. It's like it's just me. So maybe because we have less people, we don't have enough people for all the rooms. So we
No.
can join other, is fine.
Let me know if you can see that right now, because I changed the settings and it might be helping.
I can, and I'm about to go. Thank you. I'm going by.
Okay.
All right.
I've got to go to my room now, but hopefully you can all. Chris will sort you out.
Well, it looks like most of you are actually moving between rooms. Is there still someone who isn't assigned to the room? I can see you, Andrea, but I can't see you on the list to assign you.
I'm also not on the list, Albert.
Yeah, can you just choose any of the rooms that that feels good? All of you guys, if you don't have a room assigned, that would be just easiest to just choose any of the rooms that is available.
Actually, I can't see the rooms. I am assigned to room number 4, but I can't see.
What's your name? Because I can't see.
Number 4.
Yeah, but what's your name? Sorry, love.
Cristina.
Cristina, let me just move you there.
Thank you.
Okay. Andrea?
Yes, me too. I cannot see the room room 5.
Room 5. Okay.
Okay,
It
now
should be
yes.
going now. Yeah, bro. Anyone else? Okay, I'll just move the guys. Young runner. Roger. I assume everyone is now in the rooms, right? Roger and Jan, can you hear me?
Right, is this the main
Should I
room?
close it?
Huh?
Should I close it?
Is this the main room?
Yeah.
I think you need to bring everyone back now. Let's start the second breakout.
Yeah. They have 60 seconds now then.
Okay.
It's a little bit too long. I mean,
Yeah, I mean, when let me just look at the agenda. Anyway, so we're running 7 minutes late. I think that's all right. We can start. Let's see. Hey, welcome back, room 4. Could have carried on for longer, right? Right, room 2 is here. We're waiting for 3 and 5. 5 is here.
Oh.
Grace here. Right, I think we're all back.
Hi, we're back.
Okay,
Right,
I didn't see the.
thanks. Obviously, okay, right. I was just going to say, obviously, we could have carried on for much longer, but we do have other things that we want to cover today. It is a bit tight, but really useful, interesting points are already starting to emerge. So in the chat, you will now see your new room allocation. We're going to open them up again. So please join the room you've been assigned to if you can, and hopefully this time it'll be more straightforward. See you in a bit.
Is there anyone who doesn't know where to go?
I know that I
Klaus,
need to go to room 2, but I don't know. I don't see an invite like before.
I don't see a room allocation for Albert.
okay. Okay. Let me just do it. So Maria, you will be in the room. Maria.
I think number 2.
Yes, number 2. So let me move you there.
Thank you.
Sorry, it's just the windows are super small, so finding your name in there is fairly complicated. Oh, there we go. Move to room 2. Anyone else experiencing
Hi, I'm
any
sorry, I
problems?
cannot see which room I'm supposed to go.
Paula, you are on room 1.
Room 1, thank you.
Yeah. Rotimi, I think you are on the room 4.
And Albert?
Albert, let me check. I don't think you're assigned to any room, so I can just move you to one of the less participated one, which is, for instance, number 5.
Okay, I'll join 5.
Okay. Anyone still waiting, Muhammad?
Medical something in. Medical something in. Apa hao? Good. Aku pengen tips. Aku pengen tips apa dia planning your roots. Udah dia boleh kerja kes drive wine mereka coba forest ya udah ini sama ini. Mereka ini. Isso amanhã sekali. Come on, Helen. Helen, it's fun. I hate women who drive without confidence.
Oh, you can please start. Thank you.
Sorry. So we were just like actually interrupted because I think like the discussions were really good. I mean, at least in our breakout room, I think. I don't know for you, Patricia. I don't know. Is everyone back now? We lost our host.
It seems that everyone is back.
Okay, thank you, Chris.
Yeah.
Okay. Is Federico here?
Yeah, hi.
There he is. Okay, cool. Can you, sorry, because we were just like commenting that we were in the middle of a really good discussion. And then obviously the breakout room closed. Anyway, so, you know, for us it was Roger. So Roger, could you just maybe very briefly summarize what you wanted to say in the chat so that we can all benefit from it? That would be fantastic. So I'm aware that you wanted us to do some summary, and I wanted to hand over to Patricia to sort of close our session.
Yes, thank you. Just want to say that about we were discussing about data that we data resources in Latin America. We have the ones published by WHO, and also the ones published by national institutions in Peru. We have the ones that are created by the Ministry of Health, and well, about strategies in musculoskeletal research. I think that there is a good strategy. We are an institution specialized in physical medicine and rehabilitation, initiating with simple studies like descriptive studies, prospective studies. With that conclusions, we can have and made clinical decisions to improve the patient's treatment. And also we are doing our planning studies with some kind of new treatments in musculoskeletal conditions. And also last, I think it's important, collaborations with universities and also international institutions. That are strategies that we are adopting right now. And yeah, I think that's our important strategies. I think for low and middle income countries like ours. Thank you.
Okay, thank you very much. Okay, so Patricia, you need to yeah.
Yes, I'm here. Thank you.
Summarize us. Thank you.
Yes. So I hope that everybody have and enjoyed the discussion as us, as my group. So just quickly, I would like that from our group that I was leading the number breakout 3 is that I would like if Ana Espagnoli can give us some ideas, because we have a really great discussion, and I would like that everybody listen her. Ana, please, just can I with the first idea about the guidelines, please.
I couldn't hear you. Your voice, my phone doesn't work very well, and microphone. I couldn't hear you very well.
Yes, Anna, we were in our room. It's like we were talking about one of the main strategies. We spent almost our first breakout room talking about guidelines. And I really would like that if you can share what we discussed with the group.
We had a very great discussion in the room about how do we new guidelines, especially related to osteoporosis, going to be implemented probably in the next years, and it will be important that actually IFMRS can facilitate the possibility to have a representative across the world when these guidelines are going to be done. Personally, I think that WHO has a major role on guiding us. I think IFMRS can have a facilitating role across different professional society to be present when these guidelines they are going to be developed. And I think that is what we discussed on room 3, that representative should be present.
Thank you, Anna. It's like, and we get a lot of a list of solutions that we are going to share with everybody. I'm sure that everybody has even more to say, and it's very short the time, so don't worry. We are going to facilitate a document where everybody can read all the discussions. I'm going to encourage the other rooms to try to give us a brief summary about your discussion. Please, Deborah, can you please tell us what was the main discussion in your room?
So we had a great discussion with breakout room 4. So in the first breakout, we really talked about the huge gap that exists between the science and the evidence that's being created, and even guidelines, and even WHO just published new low back pain guidelines and other work, around education and curriculum, but that they don't make it up to decision makers and policymakers. And there's just that massive gap about how do we make sure that the science that we're creating, whether it's bench science, clinical sciences, makes it through up to policymakers in a way that they can understand it and apply it to their settings, and sort of look at policymakers from not just clinical services, but policymakers with respect to how research is funded. We talked about the challenges about how research is funded, and many of the folks on the breakout, they don't have any specific MSK research funding institutes available for them to apply to. So it has to be tied in with other conditions, and that makes it very challenging. So, all policymakers across all of those sort of areas need to be, there's a gap, and how do we get that information to them? And maybe we work on networks to close that gap and bring that together. And in the second group, we really talked about the importance of, specifically in countries, of having really bringing registries together to have accurate representation of data, and then countries will listen to what is happening with MSK health in their regions, but also then looking at, with the data, and what we're understanding is, how do we share training across each other? How do we amplify team-based care in an evidence-based way with competent collaborators, so that we're actually working together from the perspective of delivering evidence-based care in a timely and meaningful way that's accessible by maximizing workforce and sort of looking at the competencies. And, it was identified that, there's traditional groups that are always in the conversations, but they're not always, how do we reach out to broader groups? Klaus and Rutimini, you talked about how do we reach out to other health professions and other groups to make sure we're bringing them into these conversations and discussions. I think that reflects pretty well what we talked about in our 2 rooms.
Thank you, Deborah. Very, very nice discussion. So, Biagio, please.
Hi, so I'm not really good in this immediate, let's say, overview of what we talked about, but I will try to be, to wrap some ideas. And so we started in section 1 talking about the national health strategies and also national research strategies. And so basically, while there are some, well, we didn't have, we only had some 4 or 5 people, and we know that probably in Canada, we have some good example of national health strategies where MSK conditions are included, but for example, other countries do not have specific health strategies for MSK conditions, but let's say have some broader health strategies that may include MSK conditions, but they're not specified. And actually, MSK is never a priority in this. And this is exactly the same for the research strategies, and where you usually do not have some schemes for funding schemes for MSK conditions or MSK biology and research, but usually you have to adjust, let's say, your project to the cancer research or to metabolic research, also to have some fundings to do your own research and bone biology, bone pathology. And then in the section 2, we focused on the problem of low and middle income countries and how we can improve a collaborative research in these countries. And actually, one thing that was interesting, we talked about what kind of research we are doing right now in MSK, and probably the MSK and also the research fundings are going through osteoarthritis, right? Are going through that because it is a condition that is becoming, unfortunately, very popular. But then I actually found out that and this is not, of course, something that can be new for you, but in low and middle income countries, the problem seems to be low back pain, neck pain, and shoulder pain more than osteoarthritis. So probably research in this country should go in that direction, and we need to, provide resources to do research in that way.
Yes, thank you so much. As a middle income country, because I am from Mexico, I really appreciate all the efforts, and I am pretty sure that all Latin America and other countries, we are thankful for these kind of initiatives. So we are just missing a comment from Federico's group.
Yeah, thanks. We are coming up to time, but we do have a few more things we need to cover, so I'm hoping everyone can stay with us just a little bit longer. I'm just going to pick out a few key points which struck me in the discussions we had. In the first section, talking about the need to demonstrate the real impact of the pain and trauma of musculoskeletal conditions. Courage made the point that across Africa, they're at a disadvantage because health budgeting is already very low, and the vast majority is aimed at infectious diseases. And that's because the money, even for that, comes from international institutions like the WHO or the Bill and Melinda Gates Foundation. So these reflect the priorities of Western countries that are interested in stemming infectious diseases, who are not interested in musculoskeletal. That is an interesting point, which brings in a whole interesting new set of considerations. In the second discussion, Paula from Peru made the point that, talking about access to data, the data that they have access to when it comes to measuring the development of bones in babies is European. So it's not to do with their local population. So there's a scarcity of locally generated population data to actually inform research and practice, if you consider that what they've got access to isn't even from their own population. So those are the points I just wanted to highlight. I think we now want to just move on to the next item, if that's all right, Patricia, which is the mentoring network. So I'm just going to say a few words about that. So in all the discussions we've had over the years, mentoring is something that came up regularly as something that people felt could make a real difference in terms of advancing education and improving outcomes for MSK. So we heard that, and last year we set up a working group to develop an IFMRS global network. And we are now launching that network. And we've just created a new page where you can read all about it. So what this is a genuinely global, inclusive, person-centered approach to mentoring circles. So we're not talking about formal one-to-one mentoring here. We are talking about group mentoring, bringing together a range of people in an open space where everyone can participate and also learn from each other. And it is meant to be a very global, as I said, dynamic, organic, enabling initiative. So we don't want it to be rigid. We want to create the space for this kind of dialogue to develop. So we're offering a personal approach, and we want it to be accessible. So it's freely available to people who express an interest. There will be a selection process, of course, but how it's going to work is that we are starting with two themes: developing a career plan and developing research. And we're inviting people to step forward, express their interest in participating in one or even both of these mentoring circles. There's a form on the website. In fact, Chris will share the link in the chat, and we will email it to everybody afterwards. There are going to be 3 sessions led by 2 experienced mentors each, at intervals of between 4 to 6 weeks, roughly. And between the sessions, we also hope that there's going to be discussions and ongoing dialogue. And as I said, there will be a form. Just very briefly, the career plan is mainly aimed at young and early and mid-career researchers, looking at tips on thinking about your career, how to develop that, take it forward. That will be led by Aline Bozek and Duncan Bassett. And the second topic is around developing research in a broad sense. This is aimed at a broader range of participants, but it's mainly going to look at developing research in a challenging environment. So where there is not a lot of access to infrastructure, data, investments, knowledge, how you can still do research, how you can still balance clinical work with developing research. So we are launching these today. We are opening calls for mentees. So please do share this widely with your contacts and your colleagues, anyone who you think would be interested in taking part in these pilot circles, and we will take it from there.
Thank you, Federico. So it's time to say goodbye. I'm pretty sure that everybody enjoyed. It was really a pleasure to have you here in this roundtable. I just want to thank the speakers, facilitators, and participants. And I would like to share something from our room. It's like there is a suggestion that what if IFMRS can host a congress of all MSIK societies every 2, 3, 4 years. That would be wonderful, because it's about to try to become a community, a family, as we have been working so hard for this. Also, we would like to see IFMRS as a leader to create work guidelines for everybody, taking all in account, and also being the leading to try to get new sources for funding. So I am pretty sure that all of these ideas we are going to get in a summary, everybody. So I just want to remind you to share this information, share with your friends, share with your colleagues that we have these mentoring networking circles, that we have this IFMRS that is an umbrella for all the MSIK societies. Let's try to keep working together to try to make the MSIK community is like leading the efforts in the benefit for our patients. And it's all for me. I don't know if Federico wants to try to close the remaining session.
Thank you. Yes, very briefly, again, thank you very much from me as well. Just to reinforce the fact that, we are here for you. So please, if you haven't used our resources, if you're not signed up to our newsletter, you're not following us on social media, please do. That's a great way of keeping in touch with everything that's going on. And we always want to have your input and participation. We will be doing events like this at least once a year, but I very much like Patricia's suggestion of trying to do something quite big, maybe every couple of years. We certainly want to keep the dialogue going. So I'm hoping that all of you will continue to engage in this conversation. We're going to think about ways that we can continue this dialogue, because we don't want to lose everything we've discussed, and we don't want to forget about it until next June. We want to see if we can continue this discussion. So please remain in touch with us. We will follow up with a feedback form and also some more information on how you can continue to be engaged with us And one last thing, very last thing, is the Global Action Plan. There is also a consensus statement within that. And that means, that reflects the fact that we have to speak with a common voice. As a community, we're extremely diverse. We're only really going to make an impact if we can manage to speak with one voice, saying the same things. So let's all think about how we can do more of that. But thank you once again, and please stay in touch.
Thank you. Bye, everyone.
Thank you.
Bye.
Thank you.
everyone.
Bye-bye.
Bye.
Thanks, everyone.
Thank you.
Have a great
Bye.
year.
Thank you. Bye-bye.
Bye. Thank you.
Bye, Federico. Bye, everyone.
Bye-bye.